since you all are here. So that I've basically given, like, there are 7, we'll try and cover 7 main STEM questions. Sir, is it okay if I tell them, brief them, since we're anyway waiting?
Yes, it's fine.
Yeah. So there are 7 main stems for the questions, okay? And each stem has 4 sub-questions, okay? I have tried to give 2 marks for each of the sub-questions. So 4 into 2 is 8. I have given 1 minute time for each, which you will not need because most of the answers should be 2 words to maximum 10 words. Okay, so please let me know as soon as you finish, because otherwise if you do 7 into 4, 28 minutes there's no time left for discussion. So basically, as soon as you are done, you just scribble something, indicate, then we move on to the answers. That's what's being done, right? All the time. So it's the same pattern we'll follow.
Yes, sir. So we'll start off.
Yes, sir. Sure.
Yeah. Good evening to the this session of Examinoline. So this time we are having a question answer session like what we do in OSCE, and so because people are preparing both for practicals and theory, so this will help them in both ways. And so we have 4 faculty from 4 different institutes. We have Dr. Venkatesh from NIMHANS, Bangalore. He's professor of neurosurgery there. We have Dr. Rajesh from he's associate professor at Nizam's Hospital, Hyderabad. We have Dr. Ramesh from Tirupati SVIMS Institute at Tirupati, and we have Dr. Anil. He's from AIIMS, Raipur, and we have 2 in-house faculty, Professor Nair and Dr. Suchanda. Dr. Suchanda, you're there? So they are always there to coordinate, and Dr. Chirag is there to coordinate from student. He has become a faculty now, and he'll be coordinating all the session. With this few words, we'll have 20 minutes given to each faculty, and they will. This is both testing and teaching session. So Sachin and Dr. Sachin is from Apollo Hospital, Chennai. Dr. Milan is from Hyderabad, Yasoda Hospital, the Care Hospital, and Dr. Jabin is from Ruby Hospital, Pune. And they will be answering the questions, but I'll request all the participants to participate in answering on your own on a paper and correct it whenever the faculty tells that. If you have any doubt, use the question and answer box or chat box so that one of us will answer. We'll request the faculty to answer after the session is over. So I'll request all the faculty to look at the question and answer box and chat box after the session is over to keep on answering if anybody has any queries. With these few words, I'll request first we'll have Dr. Venkatesh and followed by Dr. Ramesh, and then Dr. Rajesh, and then Dr. Anil. So with this, Dr. Suchanda and Professor Dr. Nair have to tell anything?
No, nothing. No problem. Very nice. Okay.
Dr. Suchanda, you have to comment, advise anything for the students?
No, sir.
Okay.
Let them give, we'll see.
Okay. So I'd like to thank all the faculty.
Happy New Year to everyone. I'm late. I joined a little late. All those, sir, Nair, sir, Happy New Year. And,
yeah, same to you all. Same to you all. Okay.
Ramesh and Rajesh, I met you anyway. Chirag.
So we'll start off with Dr. Venkatesh, and please share your screen.
Yeah, I'll start screen sharing.
Yeah.
Okay. Is it visible?
Yes, sir.
Okay.
Yeah.
All right. Okay. So good evening, everyone. I'd like to thank Dr. Manas and the Brain and Spine Society and NSI for this opportunity. It's a nice refresher even for us to ask questions. So we also hopefully will end up learning something. So without any further ado, let's jump into the questions. So 7 questions. This is the first stem. So this is the first scenario. A 64-year-old man underwent surgery for a right frontal glioblastoma. And post-surgery, he underwent radiotherapy with concurrent temozolomide, followed by 6 cycles of adjuvant temozolomide therapy, standards 2 protocol. 11 months after surgery, the patient presented with progressive obtundation of sensorium. and headache accompanied by vomiting. And on examination, his GCS was E3, M5, and V3. He underwent a MRI without and with contrast, and the contrast axial image, one of the images has been selected and displayed on the right side. Okay. So based on this STEM, there are going to be 4 questions. So let's jump in. So what are the first question is, what are the possible diagnoses based on the history and the scan? And how would you differentiate between the differential diagnosis? Please name any 2 methods. That's enough. Okay. You can start. So it's for 2 marks, so you can divide it accordingly. DDs and 2 methods of differentiation. Please tell me when you're all done, because I can't see everyone on the screen.
Done, sir.
Done? Can we move on, Dr. Jabin and Dr. Sachin? Okay. So next STEM will be, next question is, so I'm presuming one of your DDs was radiation necrosis. So in that case, can you tell me some risk factors for radiation necrosis? So again, it's for 2 marks. So you can name either 2 or 4, depending on how many you want to write down quickly. So you can start now. I'll click on the time. Literally just name them. I mean, no need for paragraphs because it's OSCE. Done? Okay. I'll pause the time. Move on to the next question. Assume that the diagnosis is indeed radiation necrosis. Okay. Can you mention what are the possible mechanisms? What we understand so far, what we think are the possible mechanisms? You can just mention. There is no need to explain because obviously there is no time. I keep forgetting to start the time, but anyway. There are two prominent theories. There are at least 6 or 7 actual theories, but there are 2 prominent theories. If you can name those 2 prominent theories, I would like to know from you.
Done, sir.
Done?
Yes, sir.
Okay. Let me move on to the next question. How would you treat radiation necrosis? Okay. So 2 marks. Whatever you can think of, just give me the options. Done? I can only see Dr. Milan. I'm not seeing Dr. Jabin and Dr. Sachin. So Milan is done. Dr. Milan is done. So I'm hoping the others are done too.
Yes, sir. Yes,
okay. So I will pause. Now let's move on to the answers. Okay. So let me call first on Dr. Milan or let me start with Dr. Sachin. Okay. Dr. Sachin.
Yes, sir.
What is the possible differential diagnosis based on the scan? Do you have the answer to that?
Yes, sir. So
and how do you distinguish?
Yes, sir. So my 2 DDs is recurrence of the glioblastoma, which patient already had, or radiation necrosis.
Fine. Okay, good. And any 2 ways to distinguish?
The modalities to distinguish them is the MRS, the spectroscopy, or do a PET scan.
Or a PET scan. Okay. So let's jump into the answer. I completely agree with you. The possible differential diagnosis will be radiation necrosis or pseudo-progression. That's important. Don't forget that. Or tumor recurrence. So I'll just briefly talk about these. Okay. So tumor progression, you all know, it's GBM. There is nothing to talk about. Okay. But the other 2 things come under the category of what is called treatment changes, which is post-chemo and radiation therapy. Okay. And treatment changes can be either very mild to very severe. The most severe form is radiation necrosis. Milder form can just be radiation-induced edema.
Yes, sir.
And the intermediate form is pseudo-progression, which is basically an increase in the lesion size, which is related to treatment. And it will be just like disease, like you saw in the MRI.
Yes,
the main thing is chemotherapy is an important risk factor for pseudo-progression. Okay. Radiation alone doesn't cause pseudo-progression, but when you add chemo to radiation, there is usually a pseudo-progression becomes a risk factor. Okay. Yes, and there is a table here, which I'm sure is visible to you. There are 2 or 3 points which I want you to note on that table. First is the onset. Okay, pseudoprogression, the onset will be usually within 6 months of treatment. Okay, radiation necrosis is after treatment to several years, depending on when the patient survives. And tumor recurrence can occur anytime. Okay, the other thing which I want you to notice most importantly is that we use these important tools: cerebral blood volume, MR spectroscopy, and PET imaging, as you said. And whether you use FDG PET or FET PET, both pseudoprogression and necrosis won't be avid, whereas tumor recurrence will be tracer avid. Okay, so we'll move on to the next question. Who would like to answer? Can I call on Dr. Milan?
Yes, sir.
Can you what were your answers?
Sir, as you told, sir, concurrent radio plus chemo, sir, as a receptor for the.
Okay, so I partly answered the question. Radio plus chemo. Okay.
Yes, sir. And
any other risk factors that you know of?
No, sir.
Okay. Anybody else wants to chip in quickly before I give the answer? Either Dr. Jabin or Dr. Sachin or anybody else?
Sir, if the primary GBM, if the surgeon has not done gross total resection, he's done just barely a debulking, then the chances of radiation necrosis can be high if the tumor, previous tumor, if it already having a central necrosis.
No, I can't agree with you, because extent of resection doesn't correlate with risk for radiation necrosis. Okay. So let's look at the risk factors. So these are the risk factors, and you guys need to remember this. Okay. The most important thing, as you expect, is the dose and volume. Dose is dose of radiation. Volume is volume of the brain that is included. So if you give whole brain RT, the risk is very, very high, obviously. So the volume of brain. Second thing is previous radiation exposure. So now more and more patients are surviving for longer and longer. So sometimes you give redo radiation. So when you give second time radiation after gamma knife or previous RT, risk is higher. Then, as you said, chemotherapy, okay, increases the risk. Then location. Frontal location has the highest risk, and superficial cortical lesions have the highest risk. Okay. Yes. And some histologies, like for example, GBM itself, and some specific metastasis like RCC, lung, etc. And an intrinsic radiosensitivity of a patient, we have no way of testing this. Okay, some gene alterations have been described, but we have no way of testing it, so it's clinically not relevant. Okay, so that was the second question. The third question, we'll move to Dr. Jabin. Assume that the radiation necrosis is the diagnosis. Can you name two possible mechanisms for radiation necrosis? This is a slightly tough one. So if you know, you know, otherwise let's ask anyone else.
I don't know.
Okay, anyone else wants to chip in?
So, sir, there are two theories of radiation necrosis. One is the endovascular proliferation. The radiation causes endovascular proliferation of the vessel. The vessel gets completely occluded, and there is no blood supply, and it becomes a sort of liquefactive necrosis mechanism.
Okay.
One is, and second is there is a direct injury to the cells, the astrocytes or the oligodendrocytes, because of the high dose of radiation. So one is direct injury to the cells, and second is endovascular proliferation.
Very good. So you are correct. There are the two mechanisms are the vascular injury theory and the glial cell theory. So vascular injury theory, as you said, basically it disrupts the endothelium. So many things happen because of that. One is blood-brain barrier goes, so there is leakiness and permeability that leads to edema. Second thing is it activates certain free radicals and pro-inflammatory cytokines, all of which lead to an inflammatory milieu. Again, that leaks out into the interstitium, and there's an inflammatory reaction leading to necrosis. Third thing is it upregulates something called ceramide, which causes the endothelial cells to undergo apoptosis, all of which lead to this, basically fibrinoid necrosis and death. So that's the vascular theory. The other one is that it leads to demyelination, glial cells, because of damage to oligodendrocytes, and it also causes hypoxia and induces hypoxia protein. Okay, so that can lead to necrosis because that causes damage by free radical hypoxia mediated injury and leading to VEGF generation. But VEGF is leaky capillary, so that leads to edema rather than useful perfusion. So very good. So that answer was almost completely correct. Okay. So the fourth question was, how do you treat radiation necrosis? So this one I will go back and I will ask Dr. Sachin. How do you treat radiation necrosis?
Okay, so first of all, we have to decide whether the radiation necrosis is symptomatic or asymptomatic.
So when I'm saying radiation, sorry, I'll interrupt. When I'm saying radiation necrosis, we've established the diagnosis.
Yes, sir. But we have to define whether it is symptomatic or asymptomatic. Symptomatic in the sense in our patient,
in the patient
it looks
whom we described.
symptomatic. Yes,
in the patient whom we described.
Yes, sir. It is symptomatic, and in that case, if the general condition of the patient are fair enough, then surgical treatment is the primary modality. If the general condition doesn't allow you, then you can try a palliative conservative treatment with the help of drugs like bevacizumab.
Okay. So what if the patient is not
and corticosteroids.
Very symptomatic? Suppose patient only has severe headache. Then how will you treat?
So I think with the corticosteroids, the edema will settle down, and you may try bevacizumab. So with that, I think patient should do okay.
So you're partly correct. So you're correct actually. So treatment of radiation necrosis is a stepwise approach. Good.
Yes.
So you begin very simply by treating with steroids. So steroids are not required only for radiation-induced edema, but for pseudoprogression or radiation necrosis, steroids have to be given. Okay, irrespective of how symptomatic. If steroids are not working, the next step is bevacizumab. Okay, you should know these names. So VEGF. Okay, so bevacizumab. The thing is, in India it's difficult, but abroad almost 70% of GBM patients with radiation necrosis end up getting Avastin or bevacizumab. The third step, if it's available, you can use this. That will be hyperbaric oxygen therapy, which is both prophylactic as well as it's a treatment, but very difficult and not available everywhere. So you'll usually skip this third step. The fourth step in a patient like the one I described, altered sensorium, etc., you have to do surgery and resect the area of necrosis and reduce the ICP. So this will be the stepwise treatment for radiation necrosis. Okay, very good. So we'll move on to the next question. So this is the scenario. A 5-year-old boy is brought with repeated episodes of vomiting since 2 months. His food intake has also reduced and he complains of occasional headache. On examination, bilateral fundus, papilledema, bilateral 6th nerve paresis, and there's a very subtle right-sided LMN facial paresis, Hausen-Brackmann grade 2. Okay, so he's investigated with an MRI. Selective images I'm showing you. This is the MRI. Okay, have a look at it because I'll not be coming back to the MRI. Okay, flare and contrast, that's what you're seeing. Flare images and contrast images. So question 1. What are the differential diagnoses? Time is 1 minute. Okay, so please start. I have 2 files. It's covering up my, yeah, okay. And please tell me when you all are done so that I can stop the timers. Done? Sachin, Milan, I can see that you're done. Dr. Jabin, are you done?
Done.
Okay, great. We'll stop the timer. Next question. What further investigation is required prior to planning treatment and why? If you want to do any further investigation, what is it and why? Some of them are trick questions. So if you feel nothing else is required, you can also write that. You'll get just a full 2 marks if that is correct.
Yes, sir. Done, sir.
Okay. Dr. Milan is done. Are you done? Dr. Jabin?
Yes.
Great. Okay. Third question. What are the characteristic histological features of this tumor? So it's for 2 marks, no essays, right? 3 or 4 points or 2 points, whatever you think is appropriate for 2 marks. So please start. Whichever tumor you think it is. Sorry, I went on to the next one.
Yes, sir. Done, sir.
Okay. If you all are done, then I'll stop this one. Anyway, the next one is seen here on the screen. Please read the question. Which subgroups of this tumor have the worst prognosis? Which subgroups of this tumor have the worst prognosis? Dr. Milan seems to be done. You're also done, Sachin?
Yes,
okay.
Sir. Yes,
Dr.
sir.
Jabin? Okay, great. So let's just stop this timer. Okay. Okay, so the answers. Let me call on Dr. Milan first. So would you like to go first? What were your DDs?
Medulloblastoma, sir.
Okay.
Ependymoma.
Okay. Okay, 2 marks, 2 DDs I can accept, no problem. But do you have any more? Does any of the other two have any more?
Choroid plexus.
Sorry?
Choroid plexus tumor, carcinoma.
Choroid plexus, okay. And?
Maybe hemangioblastoma very rarely.
No, that I will not agree at all. The others I will let on to the list, but hemangioblastoma I will not agree. Because you should remember the MRI appearance, right? It did not look anything like a hemangioblastoma.
Yes, sir. Yes, sir.
So the answers, the first DD has to be ependymoma. Okay, you cannot put medulloblastoma first. And I'll tell you why. You should have noticed on the examination, the patient had bilateral 6th, but on one side there was a 7th along with that. So when you see a 6th with a 7, please remember that it's a sign of an intrinsic brainstem involvement. Okay, brainstem involvement. And you know that the facial colliculus is dorsally located. So if it has to involve facial with 6, that means the tumor has to be involving the brainstem. So in that case, your first DD has to become ependymoma. Another point favoring it is that the child is presented with repeated vomiting. ICP raise is not so much, but vomiting is so much. That's again very characteristic. Okay. So ependymoma, medulloblastoma, because they're very common in this stage. And the third DD has to be pilocytic. I'm surprised you guys have forgotten about pilocytic astrocytoma. Okay. The fourth diagnosis has to actually be ATRT. Okay, in children, atypical teratoid rhabdoid tumors, not choroid plexus papilloma. You will consider that in adults, but in children, that should be your last DD. So please remember, when you're giving DDs, the order becomes important. Based on the presentation and the age and the gender, the order becomes important. You will be graded on that. Okay. Now, the next one, Dr. Jabin, would you like to answer the next part?
Yes, sir.
Yeah, go ahead.
I will do MR spectroscopy for confirming the tumor and the grade of the tumor. And I will like to do an angio for vascularity.
So would you typically do an angio for all posterior fossa tumors if you're not suspecting hemangioblastoma? We just said it's not looking like a hemangioblastoma or definitely not a meningioma, right? So would you do an angio typically? For example, let's say it's a medulloblastoma, right? Would you want to do a DSA for that patient or a CT angio for that patient?
Yes, if it is large enough tumor, then yes.
For this tumor which I showed you? Okay, so we'll stop that. I'll ask you one more question. You said MR spectroscopy, right? So you're going to operate on this tumor.
Yes, sir.
So is spectroscopy relevant? Because once you operate and take it out and send it to the pathologist, they'll give you the diagnosis.
Yes, sir.
I told you there are some trick questions. Okay, so let's move to the answers. So the answer which I expect is whether you are thinking of ependymoma or medulloblastoma first, you need to do an MRI with contrast spine screening. Okay, that's very important. Please don't forget, almost any posterior fossa tumor, unless it's a typical solid cystic pilocytic or a meningioma, you have to do, especially in children, spine screening, because in ependymoma per se at presentation, almost 15 to 17% of the patients will have spine metastasis. Okay, and after surgery, almost 1/4 of the patient can develop spine metastasis. In medulloblastoma, the number is much higher. Eventually, if you follow these patients up, 1/3 of them can develop spine droppments during the course of the disease. So never forget about spine screening in these patients because it changes the staging of the disease. Okay. Now I'll come back to Dr. Sachin. Would you like to answer the third part of the question?
Yes, sir. Sir, but since I was thinking of in terms of medulloblastoma, so I thought the major histological feature, the classical histological terminology of medulloblastoma is a blue round cell tumor, very hypervascular and blue because they're all very hypervascular and large blue tumor. One thing, and the homerite rosettes.
Correct. Okay. Okay, now, but now I'm telling you that it's an ependymoma. Okay.
Yes, sir.
Because based on clinical history and the imaging findings, you would not put medullo first. So if I say ependymoma, very quickly, can you tell me 2 features? Any of you? Any of the 3 of you? 2 marks, 2 features. Okay, so let's move on. So this was an ependymoma. So the most important histological features is that unlike in a medullo, it will usually be sharply demarcated from the surrounding tissue. Good plane, that's what we say, right? Good plane. So even pathologically, there'll be a good plane. And the most important one is you will have perivascular pseudorosettes. So there'll be blood vessels, like you can see here, if my arrow is visible. Okay, this is obviously a blood vessel filled with RBC, and around this you will see this arrangement of cell which looks like a rosette, but it's not actually a rosette, because you see the cells are not arranged around it. It's the stromal proliferation which is happening around the blood vessel. So it's a pseudo rosette. Okay. Other than that, the other important feature is you will also see true ependymal rosettes. Okay, a true rosette means that there will be a central canal which imitates the primitive central canal during embryology, and around that you will see a single layer of cells. Okay, so these are true ependymal rosettes and canals that also you will see. And the fourth feature is that there will be degenerative changes. Most important is hemorrhage and calcification. Almost 50% can be calcified, and you can see a lot of myxoid degeneration and vascular hyalinization. But hemorrhage and calcification you have to mention. Okay, so if you're asked for features, well-defined plane, perivascular pseudo rosettes, true ependymal canals and rosettes, and hemorrhage and calcification. Okay, various types are there. I don't want to go into the histological features of each type. I don't want to go in. We'll jump on to the fourth question, which is also kind of pathological. Which groups have the worst prognosis? So Dr. Milan, it comes back to you. It's like keeping track of a quiz, man. I'm getting confused.
Anaplastic ependymoma.
Anaplastic ependymoma. Very good. Sorry?
Rela fusion.
Rela fusion positive. Very good. I'm very happy. Anaplastic ependymoma, Rela fusion positive, does indeed have a very bad prognosis. But there are other subgroups which have the worst prognosis. And this, either I advise you all to take screenshots or write it down, or go to the original article in Nature and download it. It's very easy to remember. Okay. Ependymomas, there are 3 locations, and in each location there are 3 subtypes. There are 9 totally. Okay. So I'll just show them to you. So the 3 locations are supratentorial, infratentorial, and spinal. Okay, supratentorial, infratentorial, and spinal. In each of the 3 locations, one subtype will be subependymoma. Subependymoma. So supratentorial also, posterior fossa also, spine also, subependymoma will be there. And in all 3 locations, subependymoma is good prognosis. Okay, green here means good prognosis. So you can see here also subependymoma is good. Here also it is good. Next slide I'll show you. Spine also subependymoma is good. See this. Okay, it is good prognosis. Now that leaves you with 2 subtypes in each location. One subtype is over, subependymoma. So let's take supratentorial. Supratentorial, as you guys said, there can be 2 things. You can either have a YAP fusion or a Rela fusion. Okay, YAP and Rela, you have to remember, there is no way around it. We are moving to the molecular era. You need to remember. So YAP fusion is good prognosis. Rela fusion is bad prognosis. There's no sensible way of remembering it. When you start using it in practice, you'll remember. Posterior fossa, classically we used to say ependymoma type A and type B. Okay, type A is the one that has bad prognosis. Okay, basically what that means is this is the one that has a balanced genome. Balanced genome means 23XX or 23XY chromosomes will be there in the tumor also. And that is a very bad prognosis. Whereas if there is an imbalance in the genome, that is associated with good prognosis. Okay, so you can see here, this is red. The other important thing about ependymoma A, which is not given here, which has been described later, is that they're almost always or very often H3K27 positive, like diffuse midline glioma. So that automatically means bad prognosis. And you can see that these are the 2 types which also correlate with anaplastic histology. Spine is very simple. We finished subependymoma. The other type is classic for spine, myxopapillary ependymoma, which you see only in the conus cauda area. The third one is an anaplastic ependymoma or a grade 2 ependymoma with an NF2 mutation. Here, even if it's anaplastic, it is good prognosis with an NF2 mutation. Okay, so the important things are YAP and Rela, supratentorial, posterior fossa, balanced genome, imbalanced genome. Imbalanced is good prognosis, balanced is H3K27 bad, and spine are unique variants. Okay, you have to remember this. Like you remember from medullo, you have to remember this. Okay, so that finishes this. We'll move on to the third scenario. A 25-year-old lady presents with 2 episodes of GTCS over the past 2 months. She has no other complaints, no headache, nothing. These are all real life scenarios, by the way. So seizures are controlled, well controlled on 1 gram per day, 500 mg/d of levetiracetam. On examination, no deficits. She's investigated with an MRI without and with contrast, which I'm going to show you. Pay attention. Okay. So this is the MRI. On this side is a T2 image, and on the right side is a T1 with contrast image. So this is what you're seeing on MRI. Got it? Sorry, this side is flare and this side is plain T2. I have not shown the contrast. I think I put the wrong image. There is no contrast enhancement. Take it from me, there is no contrast enhancement, okay? But you're seeing T2 and flare. So let's move on to the questions, okay? So first question, how would you manage this patient and why? Okay, time starts now. What would you do or how would you manage this patient and why? Patient has presented only with 2 episodes of seizures, nothing else, no headache, nothing. Fundus is normal, everything is normal. What and why? Done?
Yes, sir.
Okay. So let me move on to the next question. I'm not trying to pause it because it's being difficult for me to pause. You are allowed to do 2 special pathological tests. Any special kind of stain, anything you want, Mason's trichrome or silver stain, okay, anything, or immunohistochemistry, any 2 tests you're allowed to do, pathology. Which 2 would you pick and why? So quickly just mention which 2 and why. Like I said, these are all less than 10-word answers.
Yes.
I need to stop it, I think, otherwise it will give an alarm. Okay. Done?
Yes, sir.
Next question. You do a post-op MRI, it shows a small residual tumor. What would you do next? Small residual. What would you do? Same patient, huh? Please remember, all questions are addressed to the same patient. Okay. Next question. Assume that the MRI shows, on the other hand, complete excision. Okay. You have done an MRI, it shows complete excision. How will you decide what to do next and what will you do? How will you decide what to do next and what will you do? Okay. Okay. Let's go on to the answers. I think it's Dr. Jabin's turn. Would you want to go with the first one?
Yes, sir.
Yeah, go ahead. What would you do and why? Just 2 seizures, controlled, no headache. Tell me.
As the patient is asymptomatic, then...
Not asymptomatic. Patient had seizures. But
well controlled.
Yes, completely controlled with levetiracetam. Okay, right now asymptomatic, agreed.
So I will do further investigations, MR spectroscopy and PET scan for further diagnosis, tumor diagnosis.
Okay. So there is something called a shotgun method of diagnosis. Okay, shotgun method means you keep on doing tests till you hit something. Okay, so that is one type. The other one is a rifle type. A rifle shoots only 1 bullet. That bullet has to hit the mark. If it doesn't hit the mark, you've missed it. Shotgun breaks into pellets. So if you do many tests, something will hit the diagnosis. So in this case, if you're saying MRS and if you want to do something else, I would say it's a shotgun type of thing. Because what we don't need to do is, what we need is nothing more. This is a classical picture of a rogue-late glioma. Okay. And what do you need to do is you need to operate. And if possible, you have to do a supramaximal resection. That much is very well established now. Why? Because over time, if you give it enough years, remember this is a low-grade glioma. If you give it 3 years or 4 years or 5 years, nearly all low-grade gliomas will transform into higher-grade lesions. So there is no question of it remaining grade 2 throughout the patient's life. So that is the reason why you would intervene. Okay, you have to intervene. So your options will be surgery will come first. If the patient is completely unwilling, then you have to wait and watch with serial MRIs. But biopsy will be last because there's now enough data that shows that doing a small biopsy for a low-grade glioma significantly reduces the overall survival. That is a mystery. Nobody knows why. But please do not do a biopsy through a burr hole or STB or whatever. That is not an option. You have to either do surgery or you have to wait and watch. Surgery obviously would be the first option. Okay. Now we will move on to Dr. Sachin. I think Dr. Sachin's turn next. So Dr. Sachin, what was the next question?
The IHC or the stains.
Yeah, you are given 2 special tests which you can do. What do you want to do?
So I would like to do 1p19q code deletion and ATRX or TP53.
Okay, either ATRX or TP53. Very good.
Yes,
so,
sir.
Dr. Sachin, I will 50% agree with you. So again, like I was saying, right? So when you do these tests, there has to be a logic and a sequence. So 1P19Q, I will definitely agree. But before that, something else needs to be done.
IDH needs to be done.
And exactly, IDH is the starting point for gliomas. Okay, whether it's a GBM or a low grade, you will not progress without IDH. Okay, so you will first do IDH, IHC for IDH. If it is wild type, then the problem is solved. It gets classified as a diffuse astrocytoma, IDH wild type, WHO grade 2. Okay, if it is mutated, then only you need the second test, and that second test has to be 1P19Q. Okay, because 1P19Q will tell you if it's an oligo or not an oligo. Co-deleted means it's an oligo. That changes the whole thing. That's the most favorable So if you see actually these boxes, no, this is the most favorable prognosis. This is intermediate, and this is the worst. They are arranged like that. Okay, so only if 1P19Q is negative, then you break your head about P53 and ATRX, etc. Got it? So please remember this diagnostic sequence. IDH first. Based on IDH, you do 1P19Q or you don't do 1P19Q. Okay?
Yes, sir.
The next question was, you do a post-op MRI and you see a small residual tumor. So then what are you going to do? So Dr. Milan?
Yes, sir. Observe, then SRS, then surgery, sir.
Sorry?
Observe, then SRS, then surgery.
Observe, SRS, and surgery in that order. Okay. So let's see what I have to say. So volume of residual becomes important here. Okay, so that means you have to do something. So what will you do? The worst prognosis, as I said, is IDH wild type. So in IDH wild type, even a 1 cc residual can affect prognosis. So here, what you have to ideally do is if it's resectable, you will resect it. Okay, if it's IDH mutant, again, it's in between. So options also, why it is in between, you have to discuss with the patient. Whereas if it's oligo, 1P19Q co-deleted, the best prognosis, even slightly larger residuals may not affect the OS. Overall survival. OS is overall survival, sorry. So here, the value of redo surgery is doubtful. So the discussion here is about whether you're going to redo the surgery or not, because there is residual. Please don't talk about SRS for low-grade gliomas. That would be completely wrong. Okay? Keep that in mind. Now, fourth question. Dr. Jabin, would you want to comment? There is no residual. The fourth stem was that there is no residual. So what will you decide to do now and what will you do? Can't hear. I think you're muted or something. Yes, you've muted yourself. Yeah.
I will do follow-up, serial follow-up.
Okay.
Through MRI scans.
Okay.
And on the
so actually, I gave you the answer 2 slides back. When I showed you the flow chart, I arranged the tumors in order of prognosis, right? So I gave you the answer there. You should have picked it up. But of course, you can't change the answer now. That would be cheating. So this is how you will decide. Please remember, there are definitive risk factors to classify a patient with low-grade glioma as low risk or high risk. Okay. So age less than 40, the pre-op tumor size less than 4 centimeters. So 40 and 4. And if there's gross total resection and 1P19Q co-deletion, if all these 4 things are there, then it is low risk. So if it is low risk, then you can observe the patient after gross total resection. Okay. If any of these factors are not there, all these 4, any of these 4 are not there, then it becomes high risk. Then you have to again break your head about the IDH type. So if it's IDH wild type, worst prognosis, immediately you will recommend for radiotherapy plus PCV chemotherapy. Okay, because temozolomide may or may not be equivalent. I don't want to go into those controversies based on the RTOG 6306 trial. I don't want to go into that, but classically you can say PCV chemotherapy for low grade. But if it's IDH mutated, okay, then again, based on the residual, if there is no residual, you may or may not give radiation with temozolomide. So this box says that if there is residual, then you can give RT with chemotherapy. But if there is no residual for an oligo, you can wait and watch. But if it's not an oligo, you have to immediately give radiation therapy and chemo. There is no question of waiting. So wait and watch option comes only in one situation, completely resected oligodendroglioma. For everything else, either you do a redo surgery, or if redo surgery is not feasible, you have to refer for RT and chemo. Got it? That's the take home message. Quickly, we'll jump into scenario 4. 12-year-old boy. Yeah, sorry.
Just going to interrupt. We are already 30 minutes over.
Okay, we'll stop. We'll stop.
Yeah, if we have time, we'll come back.
Yeah, sure.
But it was
I didn't
very
expect
nice
to finish all. Thank you.
Yeah, no, it was very nice. I didn't want to interrupt the 20 minutes was over because I also was learning a lot.
No, I didn't keep track of time. I'm very sorry. We'll just end this.
No problem. We'll get you again. We want to learn more from you.
Okay.
So thanks, Venkatesh. And then I'll have Dr. Ramesh. Dr. Ramesh from Tirupati. And can you please share your slide, Dr. Ramesh?
Sir, you're muted.
Ramesh, we cannot hear you.
Yeah.
Yeah, now we can hear you.
So I would like to thank Dr. Manas and the NSI Scientific Committee for giving me this opportunity. So the first I will show two clinical spotters. So the timing will start after the second case. So this is the first one. Identify the clinical sign and tell the pathophysiology. I'm asking the patient to clasp my fingers, closely observe the hands. This is the first thing. The second video. So this is the image of the MRI image of the patient. So identify the clinical sign and the pathophysiology in this case. So your time starts now. If you are ready, I think you can interrupt me anytime so that we can discuss the next questions. Done? You can see Dr. Milan, Dr. Ashna, Dr. Sachin.
Yes, sir. Done, sir.
Done.
Done. Dr. Milan?
Yes, sir.
Done? Okay. Dr. Ashna, what is the first video?
Yes, sir.
Yeah, what was the first?
First was grasp reflex.
Pardon?
The first sign was grasp reflex.
No, not grasp reflex. Next, anyone?
It was a mirror. It was a mirror movement.
Yeah, mirror movements. What is the pathology involved there?
Sir, if the compression or the any injury or compression at the in the brain stem where the decussation of the tracts are happening in the lower medulla, if there is any compression there, then it may create the mirror movement, sir.
Dr. Milan, you want to do? Okay. What about the next case? Dr. Milan?
Yes.
Dr. Sachin?
Yes, sir. Next thing was the clinical sign is gelastic seizure, sir, but generally happens in the hypothalamic hematoma, but here lesion is not in the hypothalamus.
If I get the image, so because gelastic seizure is a very close DD. For this,
yes,
what is he doing actually?
Maybe emotional cerebral palsy for due to
what do you get in there?
incontinence.
Okay.
Laughter which is not normal. So what do you call that?
Emotional incontinence.
Okay.
Cerebral palsy.
Yeah. You're close. Yeah. So first was mirror movements. So basically, many theories are there, but false synapses and rational corpus callosum is one of the things. The next one was pathological laughter. So especially in this case, there is cause due to the frontal release. So there is a site called laughter coordinating or center in the dorsal upper pons. I mean, not anatomically defined yet. So disinhibition of this causes pathological laughter. You can go through this article by Dr. Sanjay Vihari and his team, comprehensive review of pathological laughter on petroclavin meningitis. Okay, this is a 44-year-old lady presented with slowness of activity since 4 years, and on examination had mask-like faces, tremors, cogwheel rigidity. So here you can see the pre and post-operative video of the patient. So I would like you to first identify the condition and the surgical procedure done. What are the indications and contraindications of this procedure in this disease? And what is the most common neuroanatomical target here, and how do you plan? So total of 3 minutes you have. Your time starts now. So just let me when you finish. I don't want you to write any detailed thing, just the main bullet points, main points, the major indications, major contraindications of the procedure. And just 2 or 3 lines about the planning. Done?
Yes, sir.
Dr. Milan?
Yes.
Dr. Ashna?
Yes, sir.
Okay. Who will go first? Okay, Dr. Sachin.
Yes, sir. So the diagnosis of the patient is Parkinson's disease, sir.
Okay.
The 3 anatomical structures which are targeted, so we will do deep brain stimulation. I think the procedure done is deep brain stimulation. The 3 anatomical locations where you do the stimulation is subthalamic nucleus 1, second is the globus pallidus internus, and ventral intermediate nucleus of thalamus.
What is the most commonly targeted nucleus?
Subthalamic nucleus is the most common targeted, sir. It covers all 3 tremors, rigidity, and
okay.
akinesia.
What are the indications and contraindications of this procedure in this disease?
So yes, sir. So indication is the Parkinson, which is not controllable now with the drugs. One thing, and second indication is all those patients who had earlier responded to levodopa, but now they are not responding. So levodopa responders and now uncontrollable, not controlled with the medicine. That is the indication. Contraindication, yeah. Contraindication is, I think, the levodopa not responder, one thing, and if there is any associated Parkinson plus, then they are not suitable candidates. Yes, young people are good candidates. Second, one more.
Good. Okay, we'll go to the answers now. Okay, it's deep brain stimulation for Parkinsonism. So basic indications and contraindications. So the duration of at least 4 years with motor fluctuations of more than 4 months. Good response to levodopa, as you already mentioned. That is more than 30% improvement in the motor UPDRS scores. So again, there is no cutoff for the UPDRS score, but they say the surgical candidates, the UPDRS score of 40 in off states. And the contraindications are mostly the atypical Parkinsonism. Main thing is dementia. So we should avoid them. Uncorrected depression with suicidal ideations. That's very important. That also you have to avoid. Active psychosis and age of more than 70. And the most common anatomical target is subthalamic nucleus. So how do you plan? No one answered that. Do you want to so many methods are there, anatomical, indirect method, direct method. In relation to any other nucleus do you know?
Yes, sir. In relation to the red nucleus, you do, sir.
You know that it's in relation to that nucleus. Okay.
Yes, sir.
So show you the planning.
Yes.
So this is how you plan. So you take 2 planes, that is one line on the anterior border of the red nucleus and one line on the lateral border of the red nucleus. Then the point where both the lines intersect is the point. From there, you take 3 millimeter lateral into the subthalamic nucleus. So here you can see. So this is the red nucleus, and this is the subthalamic nucleus. And one all the lines is the point where it intersects, and from here 3 millimeters. So ultimately, it should be at the depth of the third ventricle. The depth should be at the floor of the third ventricle. Laterally, it should be at the thalamocaudate line. This is the thalamocaudate line, and anterior margin of the red nucleus. The anterior placement of the lead should be at the anterior margin of the red nucleus. Okay. So now this is a video. This is an intraoperative video of clipping of basilar artery aneurysm. So I would like to like you to identify the intraoperative step or technique and enumerate the methods or other methods, all the methods used to achieving this, and what are the indications why you want to do this step, and what is the most common drug used, its dosage and contraindications. So you concentrate both on this is the clip being placed around the aneurysm, and this is the introp ECG monitor of the same patient. Sorry, time up. Your time is 3 minutes. If you are done, you just intimate me. So just name the technique. What are the other methods to achieve this? What are the indications of this? And what is the most common drug used, the dosage and contraindications? We have 4 or 5 questions in this, so we can take 3 minutes. But intimate me if you are done, no problem. We can proceed for the next questions. Done, Dr. Milan? Dr. Sachin?
Yes, sir.
Dr. Ashna? So, who would like to answer? What was the procedure, the technique?
It's a clipping of aneurysm, sir.
Oh, that is, but what was the ECG showing there? Did anyone notice the ECG? You want to go back to the video?
So I think the technique was cardioplegia with the help of drug. What is the adenosine induced cardioplegia you had used, and the ECG was, yes sir, ECG was basically looking for the basic brain glial activity.
No, exactly. At one point you saw the heart rate going 0, no?
Yes,
so
sir.
Cardiac standstill. So
yes, sir, cardioplegia.
So what are the other methods to achieve this cardiac standstill? One you told. What else?
Adenosine. Other is there is a cardioplegic mixture, which is a mixture of potassium chloride and I don't think there is a cardioplegic mixture that they induce.
Then anything to do with pacing?
Yes, like sir. You can do a mechanical defibrillation and pacing. Yes.
So when do you do this? Do you do this for all aneurysms, or what is the main idea behind doing this? Okay.
So if you have not achieved a good proximal control, one thing, if there is any intraoperative rupture of the aneurysm, other thing, and maybe just
any idea of the dosage of adenosine?
Okay, so you have to give 6 mg if you are giving in the central line, and you have to give 12 mg if you are giving in the PIC line in the arm. You have to elevate the arm and look for 1 minute. It will
become. 6 to 12 is okay, but it depends upon your indication.
Yes, sir.
I'll just go to the answer.
Yes, sir.
So, as rightly said, it's intraoperative cardiac standstill. So, pharmacological methods are, you have other drugs also, nitroprusside, nitroglycerin, but they have more of complications. So, adenosine is the preferable thing. Other is deep hypothermic circulatory arrest and rapid ventricular pacing. These are the 2 other methods where you can do a standstill. So basic indications are where temporary clip ligation is difficult, especially narrow corridors, deep corridor, large aneurysms, when it fails, or to facilitate clip application, like here, you have some 10 seconds time to look around for the perforators and then fix. And in synergy with temporary clipping, especially during intra-rupture. So adenosine is the most common thing. So 6 to 12 milligram, what is told is you use when that is to facilitate clip application. But you can go higher for higher doses, especially in case of intra-rupture. And contraindications like reactive airway disease, coronary heart disease, cardiac conduction abnormality. So before taking the patient for adenosine thing, in the preoperatively anesthetic checkup, you have to get a thorough cardiac evaluation done.
Yes, sir.
So this is another case, 64-year-old lady. This question has two parts. So this is the first part. So she had multiple cranial nerve palsies. The imaging is this, and the surgical procedure has been done. So you can see two angios. So the first one is the preoperative angio. The second one is the postoperative angio. This is the part one of the question. So the next part is this image summarizes all the endovascular procedures available, the hardware. So I want you to identify the various endovascular procedures and just give two examples for each. Like for the first one I have done, that's the coiling, just bare coiling. So there are many examples like helical, concerto, optima, so Azure, so many names are there, because most of the trials are being done on the names like trade name based this thing. Trials are being done like that. So you should know some examples. So can you identify these B, C, D, E, F with two examples? The time starts now. You remember the first part? What is the lesion and what we have done? Now I want you to answer the second part. So just see. These are line drawings. Schematic things so that you can roughly get an idea.
Yes, sir. First image, can you show again, sir? Drooping of eyelid, third now, diplopia 6 now, third 6, numbness 5.
Okay, let's help you. You can see something here.
Yes, sir. Yes, sir. I got it now. Yes, sir.
Yeah. Okay.
Yes, sir.
Can you answer? Yes, start off. Dr. Ashna. Okay, Dr. Sachin.
Yes, sir. So the diagnosis is this patient has got a bilateral, or maybe, yes, I don't know the image, but there's definitely right side cavernous segment aneurysm. Okay. Maybe it is on the left side also, but I am not sure. One thing, and the diagnosis done is there is a complete trapping of the aneurysm, and there is a, I think STMCA bypass is
a bypass, STMCA bypass, yes, not a trapping, but just ligation of the ICA.
Okay, okay, sir.
So what about this? What is this? Any idea?
Yes, sir.
Yes, sir. Balloon assisted coiling.
Very good. What is this?
Stent assisted coiling, sir.
Very good. What is this?
That is in between the stunt or...
It's a temporary. I'm giving a clue. It's a temporary.
Yes, sir. Yes.
Once the coiling is done, you can remove this so that the patient no need to give antiplatelets in this case.
Yes, sir.
No idea. So what this you can
say? What is flow diverter? Sir.
Flow diverter.
What is the flow diverter? What type of flow diverter is this? What is say lumen? And what is this?
This is a
inside. This is a sac. So what is it called? Okay. So basically, this is balloon assisted coiling. These are the example. So scepter, transform, hyperglide. This is stent assisted coiling. This is a temporary bridging device. So now very commonly used, Comaneci and cascade. Then these are the intraluminal flow diverters, pipeline, silk, surpass, and intrasaccular, web, luna, medina. So this is the intrasaccular. These both are flow diverters. So this is a 60-year-old gentleman, known hypertensive, presented with pain over the left half of the face, shooting, lancing type of pain, mild fifth nerve and seventh nerve involvement. So I want you to see the images, both the MRI images and the angio. Tell me what is the diagnosis and describe the diagnostic criteria and grading if possible. And what are the various surgical as techniques described for this? Only the surgical techniques. Just one word answers.
Yes,
so
sir.
if you move fast, we can discuss more. And if you don't know, you just tell don't know, then I can go to the next. Dr. Milan?
So vascular compression of 5th and 7th now, thick dollars.
Yeah, more than that. Thick dollars, you won't see this big, no? What is it? What is happening to this? You can see this? Is it normal?
Is it?
Yeah, compression caused by, okay, it's a vessel. So what is this?
Dolichoectatic vessel.
Dolichoectatic. And what are the surgical techniques?
MVD, sir, microvascular decompression.
Do you think microvascular decompression would sustain such a big compression?
Endovascular side. Endovascular.
Okay, that's another option. But that is used when there is an aneurysmal dilatation. So, intraoperative, I mean, surgical technique I'm asking. What else can you do? Can you move this somewhere from here? Can you, what do you call that?
Transposition.
Take a hitch along. They take the hitch along the and hitch it to the tent.
Yeah, it's called repositioning. Okay, we'll go back. This vertebrobasilar dolichoectasia. So the main criteria is called Smoker's criteria. The diameter larger than 4.5 millimeter at the midpons level. And you have grading based upon the sagittal and the axial images. So the more lateral it goes, the more higher the grade, the more superior it goes, the more higher the grade. And microvascular, as you already told, but its recurrence are very frequent. Macrovascular decompression or arterial repositioning. So these are the techniques. Earlier, it used to do with a suture, just directly bare suture you can put. You can use a fenestrated clip and take the vessel into the clip and then you can do a vasculopexy where you take a bite through the adventitia, which is dangerous. Wrap lasso technique, suture. You wrap it in a Teflon thing and suture it to the dura. So this is what we did in this case. And we can do the same thing with the clip.
Yes, sir.
So identify the surgical procedure. And what is the main prerequisite for this approach? And what are the alternative procedures available? One word answers. See the corridor where it is going. You can see.
Oblique.
Yeah.
Yes, sir.
So tell me.
It's a whole lip.
Yeah. What is the full form?
Oblique lumbar interbody fusion.
Very good. And what is the main prerequisite for this approach? If you want to do this approach, what the basic thing you need? This thing. What is this called? The corridor.
Yes, sir.
Yeah. And what are the alternative approaches? Or what are the other interbody fusions you know of?
Elif.
Okay. So oblique lumbar interbody fusion, the main prerequisite approach is the corridor. That is between the psoas muscle and the great vessel. You know, you already told these are the other options. So identify the type of fracture and its components. And what is the mechanism of injury? And just enumerate the options. Not very detailed.
Ramesh, this will be the last question. Huh?
Yes.
Okay.
What do you see here? Anyone?
Hangman's.
Yeah.
Hangman's.
Very good. Hangman's fracture.
Yes,
So what are the components? See, what is happening to C2 or C3?
Enterolistesis. Enterolistesis.
Enterolistesis of C2 or C3, and where is the fracture here? Bilateral?
Pars intraarticularis.
Very good.
Hyperflexor injury, sir.
So basically, it's a Hangman's fracture. So mechanism of injury is extension and compression of the upper cervical spine, unlike the judicial hanging. So what do you get judicial hanging? Judicial hanging is basically extension and distraction of the upper cervical spine. So these are the treatment options depending upon the severity. So it's a simple parse. You put a parse screw, C2, C3 fusion, and C2 to C3 anterior fusion if it's more of a anesthesia. Okay, very good. Thank you.
Thank you. Thank you, sir.
Thank you, Ramesh, for actually very good day-to-day clinical cases, and I think I'm sure the residents would have got a lot of knowledge of managing this patient, and they'll know how to manage the patients in OP and in the ward. And if we have time, we'll complete the rest of the questions later. And I'll request Rajesh to share his screen.
So now the first question goes like this. A 45-year male hypertensive patient brought in unconscious state. He was intubated and connected to the ventilator. Immediately he was normal. On day 2, he opened his eyes but was quadriplegic. The cervical spine MRI was ordered, which was normal. His eye movement consisted only of vertical movements. So there are 5 questions that follow, and I'm starting the timer. What is the clinical diagnosis? What is the site of the pathology? And describe the fiber tracks that are involved. Give 2 possible differential diagnoses and draw a labeled cut section of the lower pons. I don't know. Yeah. You're finished. Sachin, Ashna, and Milan. Okay.
Yes, sir.
This is the order. Sam, we will go. Okay. Sachin, you be ready with whenever you are ready.
Yes, sir.
So if you're done, we can discuss the question. It's a straightforward question. You're done? Done? Sachin?
Yes, sir. Done, sir.
Asma, done? Sachin, you go with the first question. What is the clinical diagnosis?
I think
What
it's
have
a
you written?
I think it's a locked-in syndrome, sir.
Very good. It's a locked-in syndrome. So
Yes,
what? Asma. Hello, Asma, you there? Asma.
Yes, sir.
Yeah. What is the second? What is the site of the pathology?
Site of pathology, the pons.
Where in the pons? Yes, you're partly correct.
Upper pons.
1/4 mark.
Upper pons.
Upper pons. Okay. Okay. Anybody else wants to take the question?
Lateral medulla, sir.
What?
Lateral medulla.
Lateral medulla.
No.
Okay. No, it's not the correct answer. It's the ventral pons.
Ventral pons, okay. Corticospinal tract.
So what are the fiber tracts that are involved? Milan. The next question is for you. Milan.
Sir. Corticospinal tract, sir. Corticonuclear tract.
Yes, very good. Sachin.
Yes, sir.
We'll give at least 2 differential diagnoses.
Sir, I think it can be a vegetative state where the eyes is just moved. Sometimes you may get some oscillations in the one.
Do not describe vegetative state immediately. You yes, require some time frame. Yes, at least 6 months to go in.
Or maybe some other, like maybe some drug poisoning can be a possibility.
Drug poisoning.
Yes, sir.
Which one?
Second thing, central pontine melanosis after correction of the sodium, but here patient doesn't have any history of sodium correction.
Yes.
Yes, sir.
Anything else? Anything else?
He's a hypertensive patient. Maybe he had a
vascular, sir. Any trauma related, any vascular compression, sir? Ischemia.
I think 5th one you might have all drawn the lower section of the pons. Any section of the brainstem can be asked. Okay.
Yes, sir.
So we'll go to the answers. So this is called as locked-in syndrome. He can't move, can't talk, only blink. Ventral pons is the tract. The other differential diagnoses are Guillain-Barré syndrome, central pontine melanosis, and periodic paralysis. You should be able to draw in the given time a legible labeled diagram of any of the sections of the brainstem. Understood? Hope you might have all drawn and you can give yourselves the marks to these things. So this is just for the completion sake. So now 32-year male is presented with unilateral dropping of the eyelid with no disturbance of the vision. Okay. There are 4 questions and then you have to answer them. What is internal ophthalmoplegia? What is external ophthalmoplegia? What are the divisions of an oculomotor nerve and how do they manifest? Okay. In the presence of a third nerve palsy, how are you going to test for the intactness of the trochlear nerve? And you need to draw a labeled diagram of the superior orbital fissure. Let's start the time. As soon as you're done, you please let me know. The time is. Milan, you have written the answers?
Yes, sir. Right, sir. Sir.
Done? Milan, done?
Yes, sir.
You've drawn the diagram also?
Right.
Done? Ashna, you done? Yes?
Yes, sir.
Yeah. All 3 of you are done?
Yes, sir.
Yeah. So whose turn is this? Asma. Yes. What is internal ophthalmoplegia and what is external ophthalmoplegia?
So internal ophthalmoplegia, this pertains to interruption of medial longitudinal fasciculus in the brainstem, interruption of or lesion.
I'm not asking about internuclear ophthalmoplegia. We are not talking about, we are asking only just internal ophthalmoplegia and external. Done? You want to try?
No, sir. Actually, I was also saying kind of.
External ophthalmoplegia is because of some mass effect over the muscles. But internal ophthalmoplegia is because of the nerves or the structures which are connecting the connecting the eye muscles like MLF and
Not
PPRF.
the correct answer. We'll go to the next one. I'll discuss the answers later on. What are the divisions of the oculomotor nerve and their manifestations? The question goes to Asma again.
Lacrimal, frontal, and nasociliary.
Lacrimal, no. Milan?
Sir, oculomotor nerve is a two divisions, superior and inferior, sir.
Good.
Superior division supplies the medial rectus, inferior rectus, inferior oblique, and LPS. MR, IR, IO, LPS.
Oblique. Superior division is going to inferior oblique also.
MR, IR, IO, LPS. Inferior division supplies the superior rest of the muscle.
We'll see the answer. How do they manifest? How do they manifest clinically? If a superior division is involved, or you just take a laser knife and cut the superior division and cut the inferior division, something like that. Okay, we'll see. We'll simplify the answer and we'll give you. Then Milan.
Yes, sir.
You're Milan. Sachin. Yes, in the presence of third nerve palsy, how are you going to test for the intactness of the trochlear nerve?
Yes, sir. So you have to bring about the function of the trochlear nerve, that is superior oblique. So for that, you have to tilt the patient on one on the opposite side.
So what have you written? What have you written?
I could not write the whole procedure, sir.
Okay. Now, in exam, you are supposed to be writing, because
yes, sir,
by the time the next question comes, your answer is already there in the board. So understand that you have drawn the diagram, superior orbital fissure.
Yes, sir. That diagram I draw, sir.
Can you show?
Yes, sir. It's not very great, but the lower one. Yes, sir. Yes, sir.
You'll be asked to do that. Okay.
Yes, sir.
So now, how do we go about? So internal ophthalmoplegia is where the pupillary and sphincter muscles are. Internal ophthalmoplegia is where the sphincter muscles and pupillary muscles are going paralyzed. External is when the extraocular muscles. Okay. If you have got superior division involvement, you will have ptosis and upgaze paresis. If you have inferior division paralysis, you will have loss of pupillary reflex and there would be no ptosis. You remember, those are simplified things that you have to look in. Ptosis, no ptosis is the major difference. In the presence of a third nerve palsy, you are supposed to ask the patient to look down. Okay. Retracting the upper lid. And when looking down, if the eye intorts, then the trochlear nerve is intact. Few people even advise to look into the fundus and then see whether the disc is rotating or not. Okay. A legible diagram of the superior orbital fissure is required, and both better a colored diagram. Okay.
Yes, sir.
Now this is the next question. In ophthalmoscopy, you have different settings allowed. Okay. So where do you use half light beam? Where do you use a split beam? What do you use blue color? And what is the use of the grid? Okay. Your time starts now. I think it's a very direct question. Please write it down. Who was the next one to answer? Milan.
Sir.
Right, man. You're done? Milan, Sachin asked.
Yes, sir. Done, sir.
Done. Sachin, you're done. Milan?
Yes.
Whose turn was that? Milan's. Milan, your turn. Tell me. Where do you use the half light?
No, sir.
You don't know. Sachin, you want to go in? Where do you use the half light beam? Half light, this one. There is a pointer.
The fourth one on the top.
Yeah, fourth one on the top. Half light. Where do you want to use the half light in the ophthalmoscope?
Yes, sir. So if there is any corneal, yes, sir. So if there is any corneal lesion or any cataract, then when you want the light to go through
yes, good. That's good. Correct. When there is a cataract, you do not want the light to go through that opaque region, and then that is where you use a half light. Next question is for Asma. What is the split beam used for?
Focusing of light.
Focusing of light. No. You see ophthalmologists, no, they will have a split beam. Where do you use with the ophthalmoscope? Split beam examination. How do you do that? What is that to do? Milan, quick. You're not written. Okay. Split beam is basically used to analyze the curvature abnormalities of the cornea. Okay.
Astigmatism.
Yeah. Yes. Where is the blue light used? Sachin.
So I think in case of when you.
Where else do you have blue light in microscope?
Yes, sir. We have blue light in microscope.
What is it used for?
For when sodium fluorescence, when we give that time we use blue light.
What is the use of blue light here?
Vessels, sir.
Nerve fiber layer.
Nerve fiber layers to ophthalmologist. Yes, you're correct. Partly correct. Fluorescent is correct. Where do you use fluorescent for the
vessels? Vessels to see the vessels, retinal vessels.
Fluorescent is basically used most in ophthalmology. It is most used for ulcers, the staining of the ulcers. You should say first ulcers. From there only, later on, you can see vessels also. It's not that you cannot see vessels. Okay. What is the use of the grid? Whose turn? Asma. Grid. Anything which has got measurements is used to measure the distance from one lesion to the other or one anatomical structure to other for the follow-up. So we'll go through very quickly. We'll go through. See, large is basically for large people, medium-sized people, and small is for the smallest people. And the half beam is for cataract, so that you do, if the partially obstructed, you do not want to go through the opaque and reflect it back into your eyes. Red free is for vessels and hemorrhages, split beam for contour abnormalities. Blue light is after fluorescent. You can even use for corneal abrasions, and even for angiograms also you can use retinal angiograms. Grid is for relative distances between the between two retinal structures. Okay. Now, what is the name of the grading system of papilledema? The arrow is pointing. There is an arrow in the picture. It is pointing to something. If you find this, what is the grade? What is it showing? And what is the grade of the papilledema? And what is the name of objective scoring system for optic atrophy? These are just one word answers. Done. Done. Yes, Milan. Sachin, Ashna.
Yes,
Yes,
sir.
sir.
Okay, Milan, start.
No, sir.
What is the name of the grading system of papilledema? Sachin?
Sir, it's a Friesen grading system, sir.
Modified Friesen, very good. It's a modified
Yes,
Friesen grading system. Okay, what is, Ashma, what is shown in the arrow? What is happening there?
Blurring of optic disc margin.
No, I'm pointing to the pointer. There's a arrow mark shown there. What is happening? At the disc margin, probable disc and its margin, there is something happening. What is it? What is the finding?
I don't know.
You're not able to see, you are able to trace this vessel, but here it is not seen, and again you are able to see. So nipping of the vessel at the margin. Okay. So this is the finding here. Understand? Okay. Milan, again it goes to you. What is the grade of this papilledema?
Grade 3, sir.
When you see this finding, what is the minimum grade that the patient is having?
Grade 3, sir. 3, sir.
Very good. It's called grade 3. What is Sachin? What is the name of the objective scoring for optic atrophy?
No, sir. I don't
know.
know.
You know, you don't know.
No, I don't know, sir.
Okay.
Primary and secondary, what we call this.
No, anyone knows? No. Okay. So it is modified Friesen grading scale starting from 0 to 5. Okay. I'll just go on show. These are not of the same eye or same side. So first thing is grade 1, where you have a halo. It's a gray one. Don't ask me black or white. Halo is something that is white. So you see Swamiji's and there is a halo all around. So it is all white. So the grayish margin that has a C-shaped or inverted C-shape, where the temporal sparing is there. When it goes all around, it is grade 2. Okay. When this all around it is there, the cup is elevated. Here also the cup is elevated. And you have the nipping of the vessel at the margin of the disc. It is grade 3. Okay. When most of the vessels are obscured at the margin, plus all the previous findings, it is grade 4. When the whole disc is completely obscured, it is grade 5. Okay.
Yes, sir.
The answer to this is, if you see this diagram, okay, this is called as Kastenbaum capillary number test. Okay. Normally, the major vessels that are there that can be identified, that is superior temporal, superior nasal, inferior temporal, and inferior nasal, arterioles and venules, which are major ones. Barring them, you are seeing small lines. Are you able to see the small lines? Yes, these lines are counted. These vessels are counted. This and they should be at least, they are usually 10 or more. Okay. If the count of these vessels is less than 7, it is called as optic atrophy. Okay. Now this is very important. If you know, you can be a 50-year man is brought to the ER with hemorrhagic stroke requiring an emergency decompressive craniotomy. He was on low molecular weight heparin for his deep venous thrombosis and on aspirin for his cardiac stents. Okay. So how will you evaluate
Rajesh, this will be our last question.
Sir,
this is the last question. 20 minutes over. Now you can finish this question fast.
How will you evaluate the platelet functions? How are you going to reverse the effect of aspirin? How are you going to evaluate the effect of low molecular weight heparin? And how are you going to reverse the effect of low molecular weight heparin? How are you going to evaluate the platelet function in this case? What test you are going to do for platelets in this case?
Okay, sir.
Yes, sir.
Us? Done? Sachin, done? Ashna? Ashna, you are
Yes,
muted. Sachin, tell me, how will you evaluate the platelet function in this case?
Okay, sir. One thing is we'll do BT and CT, bedside bleeding time and clotting time. One thing, and then second thing is PT, APTT, and INR.
Why PT, APTT, and INR for this case? What do you want? How will you evaluate PT, APTT? PT and APTT are for what?
No, they're for the low molecular weight heparin, not for platelet.
Low molecular weight heparin also, APTT is not the correct. It is only for heparin. Okay. It is not for this. Okay, how are you going to reverse the effect of aspirin? You want to take the patient for surgery. How are you going to?
Sir, one thing is better to replace the platelets with ideally single donor platelet. If you can arrange, that is the one thing.
Platelets, yes.
Yes. I think some soda bicarbonate sometimes platelet.
Desmopressin.
Very good.
Desmopressin.
Very good.
Desmopressin. Yes.
Very good. What will it do?
Sir, it 1 milligram factor. I think it's.
What will it do? Discuss it in 2 minutes. How will you evaluate the effect of low molecular weight heparin? Don't know. Okay. How are you going to reverse? So we will go through this. Stop here. So I'll request you to read these journals. They are very simple journals and give all the answers to these questions. Okay. You can call me later and get. So if the patient is on aspirin, so the best bedside test is BTCT. But what they prescribe in UN standards is PFA 100. Okay.
Yes, sir.
That is by some Siemens company. It is similar to that of your BTCT, but a bit more advanced. In case you have to reverse it, you have to give single donor platelets, or you have to give desmopressin, or you have to give recombinant factor 7A concentrates. Why desmopressin? Because 10% of the platelets that are sequestered in the spleen, you can bring them out by giving desmopressin. Okay, if the patient is on clopidogrel, which is not the case scenario, but for completion, I am telling you, platelet agglutinometric tests you have to do. Okay. And PFA 100 is not going to be useful, and you are treating in the same way as for aspirin. Same as for ticlopidin, none of the lab tests are valid, but treatment remains the same. So this is for antiplatelet drugs. If the patient is on heparin, so the lab test is activated partial thromboplastin time. FFP is contraindicated if you are to reverse because it will give an additional antithrombin. So stop infusion and you have a reversal agent, protamine sulfate, that you can very well reverse. The action of this is also very limited, 4 to 6 hours only. So low molecular weight heparin, we have a problem because it acts for 24 hours. You have to see for factor 10A activity, which actually is probably not available in many centers. Protamine sulfate is partially effective, but the advantage is 1 milligram is the conversion factor. You can give PCC, prothrombin concentration, and you can also give recombinant factor 7. Fondaparinux and idraparinux, these are pentasaccharides. They are very long acting. Idraparinux is given once in a week. So you literally do not have anything, but they say that recombinant factor 7A is useful. Warfarin, you have to give vitamin K and other vitamin K dependent PCC and FFPs and this thing. The main crux is you should not be giving it IM. You should be taking water soluble one and you should be giving it intravenous. Okay. That's all. Thank you.
Yeah, thank you, Dr. Rajesh. As usual, an excellent testing and teaching session. And every time you do better. And I don't know how it can be better next time. But we'll have you next time again. So I request Dr. Anil to, Rajesh, can you please stop Anil to share your screen? Yeah.
I've shared, sir. Am I audible, sir?
Yeah. So our number of participants actually have not reduced. From the beginning is the same until now. So that only tells that all of you are doing very good teaching session, and you have very interested participants also.
My greetings to all. My screen is visible, sir?
Yes, yes.
So I will focus mainly on practical point of view, as all residents told that they have finished their theory exams. So this is clinical case scenario. This 50-year-old lady, she presented with the facial hyperesthesia and difficulty in mastication and chewing. So question 1 is, what is probable diagnosis? I'm not seeing this time.
You have to click on that. You have to click on the timer, then that scroll will come, then the bar. Just Sriram, can you tell how to do that?
Just take your cursor near the timer, sir.
You know, I clicked.
You click on it.
Yeah, I think you have to go to the view so and do it. You are not gone to the view.
No, I think he's trying to present. Anil, you're presenting from a PDF.
I downloaded actually what Mr. Sriram shared with me.
Okay. Does the timer work in PDF? I don't think it does.
No, it's not working.
Sir, can you stop sharing, sir? I'll run it from my screen.
And make it full screen.
Yeah, that would shall I stop sharing?
Yes.
Yeah, so this is clinical case scenario, as I told earlier. This 50-year-old lady, she presented with the facial hyperesthesia and difficulty in mastication and chewing. So what is the probable diagnosis? Classification, management plan and approach. We will discuss later this name of triangle and boundaries of triangle. So when you all finish, please tell me. Please let me know. Have you finished?
Yes, sir. That's it.
Yeah, please tell me probable diagnosis.
Sir, probable diagnosis in order of priority is trigeminal schwannoma, with the extension into the Meckel's cave. One thing. Second thing, chondrosarcoma or chondrosarcoma.
Excellent, but that does not annex actually that much, but excellent.
Yes, sir. Yes, sir. Classification for trigeminal schwannoma is Jefferson's classification. Sir.
Yeah, please elaborate that.
Yes, sir. So,
please elaborate that classification.
Yes, I think, and I don't.
Okay. How would you manage this patient? What would you?
Sir, I think this patient needs two approaches. One is the conventional retrosigmoid approach, one thing, and second thing for the part which is in the Meckel's cave, the Kawase approach, middle cranial fossa approach. Sometimes, rarely through retrosigmoid craniotomy, supra meatal drilling, you may the tumor is soft, you may get the part which is in the Kawase. It's called RISA approach. So that is the approach.
Name of the triangle?
Name of the triangle is a Kawase triangle, sir. The boundaries are GSPN is the laterally, arcuate eminence is the posteriorly, and medial border is the petrous ridge.
And you are partly correct. That your diagnosis is correct.
Yes, sir.
Trigeminal swallow, multi-compartmental.
Yes, sir.
There are actually various classification schemes for this pathology. Jefferson classification, as you told, one is SEMI's classification and Kawase MP classification.
Yes, sir. Yes, sir.
SEMI classification is widely accepted, and these kind of pathology can be dealt with the single approach actually. Zygomatic transpetrosal. Zygomatic transpetrosal. These pathologies can be. Mr. Siram, can you see next screen? Next slide. Next. So this is zygomatic transpetrosal approach. These pathology, as you can see here, post-operatively this is scan. So zygomatic transpetrosal approach, these are one stage removal of such kind of tumor, and these have certain advantage. So various approaches has been described for this kind of tumor. Tumor is predominantly localized in posterior fossa. We can suboccipital approach. If these are predominantly in middle fossa, then these tumor can be dealt with frontotemporal, extradural, interdural approach. And if these are predominantly in middle fossa and posterior fossa and going infratemporally also, then these can be dealt with, in particular in this case, then this can be dealt with zygomatic transpetrosal. Next slide. These are the boundaries of quadrilateral. These were described by Kawase, one of the largest triangle in this region. And this we can see here GSPN, and anteriorly it's bound by mandibular division, part of Gasserin ganglion here.
V3.
And here superior petrosal sinus and inferior petrosal sinus will come inferiorly. So these trigeminal schwannomas go by expansion, not by destruction. But the cool thing about these tumors is only destruction will be there in almost 70% of cases. So we don't have to drill necessarily Kawase triangle. That actually will be already, that bony removal will be done by. So one thing, these tumors can be removed by single approach, as you told correctly. Expression is there significantly in posterior fossa. These tumors need two approach also. Next slide. Yeah, this is question number 2. This is cadaveric dissection actually. This given image depicts endoscopic view from within sphenoid sinus. So you have to identify all labeled structures. Label this A, V, and C. Please tell me when you have done. Remember, this is endoscopic view from sphenoid sinus. Have you done Milan?
Sir.
Yeah, can you tell me?
A is a chiasmatic groove, sir.
Or is it carotid prominence?
Sachin?
It's a carotid prominence, sir.
A.
Yes, sir.
And B?
It's just that, I don't know. C is the clivus. B is cavernous sinus, sir.
No. This is optic protuberance. Here, this is endoscopic view within sphenoid sinus.
Yes,
but
sir.
we'll see after doing bite sphenoidotomy. This is the view after that. So this is optic protuberance A on bilateral side. This is lateral OCR, opticocarotid recess. Lateral opticocarotid recess.
Yes, sir.
And this is sellar floor. This is sellar floor C.
Yes,
and this one we are seeing here, this is clival recess.
Yes, sir.
And here medial opticocarotid recess will come.
Yes, sir.
So means what will be your extent of bony removal in pituitary surgery? Sachin.
The extent of bony removal in pituitary surgery, sir?
Yes.
Yes, sir. So you don't cross the carotid prominence laterally, or this carotid opticocarotid recess inferiorly till this clivus, sir, the clival of the sella, and anteriorly
and how you remove tumor?
Okay, once the eggshell drilling of the bone is done, so or if the once the bone is removed,
you have open dura. You have open dura. Then how you will remove tumor?
Okay, so if based on the how is the consistency of the tumor, you choose your instrument. If the tumor is soft, you take a ring curate, and with the ring curate, you have to debulk the tumor. And for debulking, in order not to have the arachnoid prolapse centrally, so don't chase the central part initially.
I am asking about direction. Means you will start from
Yes, sir. Yes, sir. The antero above and below, antero superiorly first, and then the lateral corridors, and then the
no, means if you are going to start anterior means
last, sir.
So you will start your decompression posteriorly,
yes,
then you will start inferiorly and laterally.
Yes,
then
sir.
you will go superiorly and laterally, and then you will go anteriorly.
Okay.
Descent of diaphragmatic sella that complete your resection.
Okay, sir.
Resection has been completed. If it's not premature, means what you are saying, if you are starting anteriorly first, that will call premature descent of diaphragmatic
of the arachnoid prolapse. Yes, sir.
Arachnoid prolapse.
Yes, sir. Yes, sir.
Next slide, Srimanji. So this is clinical case scenario. This 40-year-old gentleman, he presented with the coarseness of facial features, macroglossia, enlargement of hands and feet. And he also has been experiencing worse glycemic control on background of type 2 diabetes mellitus. So which is the most probable diagnosis for this patient? Ashna?
Probably it is acromegaly due to a pituitary tumor.
Excellent. And how you will evaluate and do further workup for this patient?
Hormonal workup and MRI, plain plus contrast. If a spectroscopy is available, we'll do that also.
Spectroscopy, how it will help you?
If it is benign or malignant or the kind of tumor it is.
Okay. So what hormonal workup you will do?
FSH, LH, TSH, growth hormone.
And? You need to do entire workup. You need to do
entire hormonal
profile, prolactin, growth hormone, insulin growth factor 1, testosterone, estradiol. You need to do entire workup. And apart from you need to do establish endocrine workup, endocrine diagnosis. Then you need to establish anatomical diagnosis. And apart from that, what further workup you will do for this patient?
Ophthalmic test for visual field acuity.
Yes.
Scotoma.
Yes.
Papilledema, presence or absence of papilledema, grade of papilledema.
Mm-hmm. Will you find papilledema in this kind of patient?
Mostly no, sir.
And what findings you will see in specifically you will look for in radiology, MRI and CT?
Sir, visual field defects we can see.
I am asking about radiology, MRI and CT. What you will look for?
I will look for extent, size and extent of tumor, whether it is compressing, extending to optic chiasma, or extension or involving the cavernous sinus.
Yeah, okay. You will look for means paracellular extension, supracellular expansion, position of optic chiasm, and involvement of carotid. All those features you will look for. Sriram, can you share next slide? And his endocrine profile shows raised insulin growth factor and growth hormone. How would you manage this patient? What approach would you do? Will you treat surgically or medically?
So both surgically and medical.
No, what is line of treatment, management of choice? Sachin?
Sir, since sir, this is a big tumor and which is coming into the sphenoid sinus and almost has completely occupied the sphenoid sinus. If you give a conservative treatment with the somatostatin analog, there is a chance of CSF rhinorrhea. So I think more than conservative, a surgical treatment is better in this case. We will get a tissue diagnosis also, one thing, and if there is any compression on the optic nerve or that also will be removed. This is a large tumor, sir.
Okay. Irrespective of size, irrespective of compression on optic nerve, is this patient also radiology you can see, you don't expect visual impairment in this patient?
Yes, sir.
Irrespective of, suppose this tumor is small, suppose 1.5 centimeter, how would you treat this patient? How would you treat this patient?
Then even if the glucose, the growth hormone level and IGF-1 level are high, one level is not enough. You have to do it at least 2 or 3 times, one thing. Second thing, you have to do oral glucose challenge.
You have established diagnosis. This is growth hormone secreting adenoma. You have established diagnosis. And this patient does not have any visual impairment. Visual ophthalmology is absolutely fine. And how do you treat this patient? What would be your treatment of choice for growth hormone secreting pituitary adenoma?
Then you can try conservative treatment with the somatostatin analog like octreotide or somatostatin like that.
No.
Surgery, sir.
Growth hormones, excellent. Growth hormone secreting adenoma, the treatment of choice is surgical excision. And please discuss postoperative complication. What postoperative complication you will expect in these kind of patients? Please only enumerate all those complications. You can include intraoperative and postoperative complications. Milan?
Yes, sir. Intraoperative, sir, injury to any vascular structure, ICA, and injury to optic nerve, arachnoid leak and CSF leak, post-operative infection, CSF rhinorrhea, and intrahypothalamic injuries. There is electrolyte imbalance, which may go into diabetes insipidus.
Excellent. And one more complication, which is particular to this growth hormone secreting adenoma, which is not there in other pituitary pathologies. What is that complication? And what is the most common cause of mortality in these kind of patients?
Cardiac, sir. Cardiac.
Excellent, excellent. What cardiac findings you will see?
Arrhythmia, sir. Arrhythmia and persistent hypertension.
Excellent. Persistent hypertension and cardiomyopathy. All those findings you will see.
Yes, sir.
And what are your criteria for endocrinological remission, biochemical cure?
Less than 2.5 on nanogram per ml.
No, current guidelines. Current guideline. That is age adjusted IGF levels and level of growth hormone less than 1 nanogram.
Growth hormone less than 2.5, sir. OGTT should be less than 1 and IGF should be less than 5.
No, current guidelines says less than 1 growth hormone level.
Oh, okay.
Next slide. Next. So please spot this diagnosis. Radiology you are seeing already. Milan?
Sir, is bilateral, sir, NF2, sir.
Yeah, excellent. So what are your definitive criteria for diagnosis?
It's bilateral vestibular schwannoma, or it's a definitive criteria, sir. Bilateral vestibular schwannoma, it's definitive. It is unilateral, then age less than 30 years. And associated like the meningioma, schwannoma, glioma, or post-juvenile posterior subcapsular lenticular cataract, sir.
You forgot familial history. Familial history also.
Yes. First degree relative, sir. Less than 30, first degree relative, sir. Yeah.
So you read that. And Ashna, what are the strategies to preserve facial nerve in these kind of patients?
Radiotherapy.
No, strategies to preserve facial nerve during surgery. How would you preserve facial nerve in this kind of patient?
Using neuronavigation and advanced microscope and neuromonitoring.
No, neuronavigation, how to help in during surgery? Sachin?
Sir, intraoperative facial nerve monitoring with the help both the direct nerve monitoring and the corticobulbar monitoring, the corticobulbar MEPs. One thing, and second thing about the surgical technique, if you drill the IM and then start tracing the seventh nerve, the chances that you'll preserve the seventh nerve are better. So rather than tracing the seventh nerve from brainstem towards the IM, you drill the IM and trace the nerve from brainstem from the IM to the.
What are the two positions where? What are the two positions where position of facial nerve is constant?
Anterosuperior is the most common one, sir.
Two places means near brainstem and near IM.
Yes. Okay. No problem. What is the constant?
Facial nerve is constant.
Yes, sir.
And one thing you will use intraoperative monitoring, that is fine. And what are the other thing you will use during your surgery? During maybe it's surgical technique or maybe other
intracapsular removal.
Intracapsular. So rather you should call it extra arachnoidal.
Yeah.
Extra arachnoidal. You should preserve arachnoid. Because as it is said, arachnoid is the best friend for neurosurgeons. So you should try to preserve arachnoid. If you are preserving arachnoid, then you won't injure all these kind of structures. And one thing is any role of preoperative identification?
Yes, sir. Preoperative identification of the facial nerve with the help of DTI will give you a rough idea of where the facial nerve is lying.
No, not rough idea. Excellent, excellent.
Yes, sir. Yes,
Not
sir. Yes.
rough idea. Actually, in constructive interface steady state,
Yes,
you can
sir.
identify almost 60 to 80%.
Yes, sir.
And
Yes,
DTA tractography, you can find almost more than 90% of times.
yes,
Facial
sir.
nerve.
Yes, sir.
You can identify preoperatively.
Yes,
You
sir.
can use your technique of extra-arachnodal dissection. You can use intraoperative neurophysiology. And what are the anatomical landmark you will use to identify facial nerve? Anatomical landmarks.
As you said, the two places where the facial nerve is constant, one is IAM and brainstem. So those two are anatomical landmarks.
Yeah, but near brainstem, what are the anatomical landmarks?
Oh, okay.
So some pontomedullary sulcus. Have you heard that name?
Yes, yes, sir. Yes, sir.
Lateral to pontomedullary sulcus, just anterior cochlear nerve, almost 1 to 2 millimeter anterior to cochlear nerve.
Yes, sir.
And anterosuperior to choroid plexus and floccules.
Yes, sir.
These are the anatomical landmarks you can identify facial nerve. So facial nerve is actually very important to preserve all in these kind of patient. Actually, this has become a standard of care, and patient does not care whether you preserve anatomically or not.
Yes.
Patient care about whether its function is intact or not. Okay. So one more thing, time is limited actually. So you should read in the neurofibromatosis when you will operate these kind of patient and what are the criteria for surgery. That also you should read. Chirag, next slide, please. Next. So this young boy, he presented with history of road traffic accident 1 month back, and he had neck pain and weakness of all 4 limbs. So what is your diagnosis, Ashna?
Condylar fracture.
Which one? Sorry.
Condylar fracture, type 3.
Condylar fracture. Sachin?
It's a odontoid fracture, sir.
Excellent.
Type 2 odontoid fracture, sir.
Excellent, excellent.
Yes, sir. Yes, sir. And
how would you classify these fractures?
Sir, name I forgot.
Type 1 is base.
Type 1 is apical, sir. Type 2 is through odontoid and base, and type 3 is involving the body.
Okay. Yes. And then how would you manage all these kind of patients? Means criteria of instability, and how would you manage?
We'll be able to reduce, sir, a transodontoid screw, sir. Otherwise, posterior C1, C2 fixation.
Okay. This patient has actually 1 month old history, and on traction, this patient did not reduce. So how would you manage this patient?
C1, C2 fixation, sir.
Means where you will put a screw in C1 and where you will put in C2?
C1 lateral mass, C2 pars of pedicle.
Pars of pedicle. Okay. So, Sachin.
Yes, sir.
What are your various strategies for fixation in CVJ? Means where all you can fix. Means while dealing with CVJ pathology, irrespective of anything, whether it's trauma, it's congenital. Yes, so irrespective of anything, means before doing surgery, you should be well versed with all kind of fixation techniques.
Yes, sir.
So means there can be various scenarios. Suppose this patient has anomalous vertebral artery, you cannot put a screw C2 pedicle, you cannot put a screw in C2 pedicle.
Yes, sir.
What are the various scenarios and various techniques you can do fixation in CVJ?
Yes, sir. So there are techniques which are done anteriorly and posteriorly. Anteriorly, only technique is the trans odontoid screw. One thing. Posteriorly, you can do C1, C2 just wiring, or you can do C1, C2 wiring with some bony iliac bone graft, or you can take a bone from the C2 body itself, C2 spinous process itself, and put it there. Or sometimes you can do wiring from 2 sides in order to avoid the angulation movement. So that is one. You can also put the clips, but the clips are, I think, absolute now. Nobody uses clips. One thing. Second thing, then the newer one is C1, C2 stabilization, as Milan said. C1 lateral mass and C2 either pars or pedicle. One thing. Second thing, what Dr. Atul Goyal does is just the transarticular plate and screw. That is one thing. So if you are not able to achieve a good reduction, then you may include the occipit, that is occipito-cervical fusion. Just to use occipit as a lever and achieve the reduction.
Well,
transarticular cervical.
Oh, so, transarticular also. Transarticular.
First of all, means wiring. You should not. These techniques works well in pediatric patient.
Yes, sir.
In adult patient, the technique actually almost most of the times fails. Means I've done many revision surgeries for means adult pediatric who has been previously wiring has been done, and we have revised many patients.
Yes, sir.
So, Sriram, can you share next slide? These already last one. So these actually we already have discussed type
Anderson and
physiology classification. Next slide. Yeah, this is also same scenario. We'll discuss simultaneously after that. This is a young male. He presented with neck pain and progressive weakness of all 4 limbs. So can you identify vascular abnormality? I'm pointing this here. Can you identify vascular abnormality, Ashna?
Vertebral artery compression.
Can you see properly here? Actually, this image is not zoom. Can you see properly here?
No, sir.
I'm pointing arrow here.
Your pointer will not work because I am projecting.
Oh, sorry. Sorry. Can you point here where I'm putting my pointer?
I will not be able to see also, sir.
Hypoplastic vertebral.
Okay. Okay. So you can look carefully actually before doing any CVJ, before doing surgery, you should do vertebral angiogram for all these patients. Here you can look abnormality. One abnormality is there. So Sachin, can you identify this abnormality?
No, sir.
Leave this. Suppose one anomalous vertebral artery is there. You have done angiogram, but anomalous vertebral artery is there. So how will you proceed for that case? Means how will you operate? What will your strategy for that case?
You can get the pre-operative 3D images, or you can get the 3D implant also done. You can have a simulation on that. The strategy will be to drill the transverse foramen and to mobilize the vertebral artery and then fix your screws.
This particular, basically pertaining to this area, there are 2 vertebral artery anomaly which are important to us while dealing with fixation. One is in this case, this is
Anil, this will be our last question, okay? Because we are
This is fenestrated vertebral artery actually.
Okay.
One is fenestration and one is persistent first intersegmental artery. In fenestration, one branch go as normally and one branch go below C1. So you need to do angiogram in all patients. You are doing section, you need to do angiogram in all patients. You need to identify this patient. Chirag, can you say next?
C1 lateral mass will be tough in this case.
Yeah. Next. So these are various fixation technique for C2. Pedicle screw you can put, pars screw you can put, and translaminar also you can put. Next. So you need to check wisely. As already this migrant that is risky. Pars pedicle laminar is safest technique all these patients. Next. You mobilize vertical artery and C1 screw has been put in this patient. So you need to read means what are starting from occipital plate, bicortical purchase you can get in this C1 lateral mass by lateral mass pedicle and translaminar. This last question. Just can you identify the level structure and given image? This is pathological dissected specimen. This is A. This is B and this is C. A, B, and C. So Sachin.
Not able to understand the specimen.
This is no, it's man.
B is ACA.
Okay.
Yes, excellent.
And A is MCA.
Yes, excellent.
And B is ACA, sir. A1.
Okay. I got it now.
No, this is written here, man. So you don't have to sometimes. You
Yes,
don't
sir.
have to use your brain actually. Normal circle. It's written here.
B is the A1, C is the anterior communicating, and A is the main trunk of the middle cerebral artery.
Excellent.
Yes, sir. Excellent.
So Dr. Anil, can we stop? It's 9:45.
Yes, sir.
Okay. Now the students are interested, but for the logistic people, we have crossed 45 minutes, so I have to stop. So,
yes, sir.
But then it was very interesting, and it was very interesting for the students. And I'd like to thank all faculty, Dr. Venkatesh, Dr. Ramesh, Dr. Rajesh, and Dr. Anil for participating. And I like to have Dr. Nair to give some comments and Dr. Chandra for the students. Advice for the students.
Yeah. Fantastic presentation by all the 4 faculty. What I will do is say my thoughts on all the questions. I will write to individual faculty. But it was wonderful because especially I have so many points to discuss with Venkatesh, then everybody, because I have noted, but then after sharing your talk again, I will write something. This is, you have done, all of you have done excellent, beautifully prepared, but somewhere where we could have made it a shade better. I will pass my comments to all of you. And Manas, you should send this presentation to me. I have to sit and read, listen to this again, and then only I have jotted down something. Whole paper I have written, but still I have to listen again.
I will send the recorded. Actually, it is available in Google, sir. It will be, if you just type Examinoline 15, it will come. But I'll send you the recording one, sir, recorded one.
Tomorrow
Yes.
Sunday. I will
I'll send it to you.
Okay, very nice. And it was more of learning for me. Beautiful. And he started off with Venkatesh, like real, which opening batsman? I should tell. Brian Lara. Was he opening batsman? Lara style. He did it very well. Everybody. So nice. And some small difference of opinion to some other things I will let you know. Not for in this in front of students, but I will let you know what I thought for examiners. Okay, very nice.
CC to me also, sir.
Yeah, definitely, 100%. 100% I will send to you, Suchanda, also.
Yes,
and
we need to learn.
Beautifully done. Okay, very nice.
Any comments for the students?
I think only.
Yeah, everything. I think. I mean, I must say that some of you are so well read. At your state, I never knew half the things. So you all are well read, but still, I think you should read more and more, and you should practice more and more. It's not only for you all. We all come here and we too learn so many things. I mean, so many things we learn, and it becomes a revision for us as well. The learning is always a continuous process. And the best thing is you can assess yourself where you stand, and that's what should benefit you. I mean, these exercises you cannot cover everything, but whatever is being done, that gives you an insight where you stand, and then accordingly you can prepare. So good luck to all of you, and we'll see you again. Yeah. That's all.
If you do not know the answer, tell I don't know. Instead of, especially I have seen Sachin just talking something like internal, come to question, what about internal ophthalmoplegia, external ophthalmoplegia, just beating around the bush. Don't do that. You tell I do not know the answer. There is no guesswork here. Lastly, he showed one angiogram just to show ACA, MCA. It is just entry question for MBBS students. That also you should tell. You immediately told I don't know. Like that, you just think and answer. Okay. Okay. Sachin only. Others say.
Yes, sir.
Sachin is the only fellow who just tells something which you don't know, and then very difficult to withdraw that. Once you have told the answer, you cannot withdraw that answer. No. So immediately the examiner will catch you on that and will put you there too. That is the problem. Like that, Anil's first case was trigeminal schwannoma. You told dumbbell. It is actually going to infratemporal fossa also, which you never looked properly. You told Meckel's cave, you told posterior fossa, but it was going to infratemporal fossa. So examine very carefully and then answer. Okay,
sir.
Yes, sir.
Yeah, I'd like to thank Dr. Pradeep Tripathi, Professor Neurosurgery from Bhubaneswar. He's been actively participating in the chat box, giving a lot of tips for the students. And I'd like to thank Dr. Chirag for coordinating the event, and Mr. Sriram from Icon Life Sciences for looking after the logistics. Thanks all the faculty and thanks all students, Sachin and Jabin and Milan, for volunteering, because it needs a lot of courage to volunteer in front of the whole India. I mean, we have international people also watching this, and means I know that Professor Chandra said made you overconfident, and Professor Nair said that you people have to read more, but there should be introspection. You know what you have to learn and what you are good at and what you have to improve on. So please don't be afraid to volunteer next time. Don't be afraid. Don't take this critics to heart, and be bold. Come again. With these few words, I'd like to thank all the faculty, and a letter of appreciation from NSI and BAS will come to you in email. Accept that and acknowledge after you receive. Thank you and good night. And we'll meet again next month, first Friday at 7:30. And bye for today.
Oh, first Saturday at
7:30 p.m. Every month, first Saturday.
Okay, bye. Happy New Year.
Thank you, sir.
Thank you very much.
Happy New Year and thank you.
Bye.
Bye. Thank you, sir.
Bye.